Hi guys, I hope you are doing well and had a great winter holidays. And today we are going to discuss another anesthesia subject that is called malignant hyperthermia. And this term should be known by specialists like anesthesiologists only because they are using inhalational anesthetics. And inhalational anesthetics represents the most common and most often trigger to produce this malignant hyperthermia. Estimation of malignant hyperthermia is very low or low, like 1 to 5,000 or 1 to 100,000 anesthesia. And it is mostly during induction of anesthesia because you are giving the first doses of inhalational anesthetics. Let's see drugs that can trigger malignant hyperthermia. They are inhalational anesthetics, and you see this column like desflurane, enflurane, halosan, isoflurane, methoxyflurane, and sevoflurane. And you should know that nitrous oxide is the only inhalational anesthetic that does not produce or does not cause MH. And succinylcholine is intravenous muscle relaxant depolarizing one, and it's the only non-inhalational anesthetic that trigger malignant hyperthermia. This column is main one that trigger. Pathophysiology, of course, this occur at ryanodine receptor 1, that is a dominant mutation, and there occur activation of calcium released from endoplasmic reticulum from muscles and produce contraction, and of course some release of worm. As you see, ryanodine receptors are activated by elevated calcium levels and known as store overload induced calcium release, or SOICR. And mutant receptors are activated by lower calcium levels. And volatile anesthetics that we counted lower the so-called store overload induced calcium release threshold. And of course, it triggers release and contraction. In malignant hyperthermia, the calcium level repeatedly exceeds the lowered threshold and increasing cytosol calcium concentration. As these ones are triggered, which increase release of calcium, increase of muscle contracture, hypermetabolism with consumption of ATP and hydrolysis of this one by myosin, and cause increased temperature or release of worm, increased contraction, increased consumption of ATP, and increased release of worm. And dantrolene, it's a drug that is RYR1 receptor antagonist that inhibits this store overload induced calcium release, or SOICR. Can we test a patient for malignant hyperthermia, especially if patient is susceptible? Of course, we have two tests like caffeine halosan contracture test and RYR genetic testing. A caffeine halosan contracture test is a gold standard and requires muscle biopsy, which is invasive and is specific only 20%, is specific 80%, and 20% give false positives. But every of the tests that are invasive are done not so often. And the second one is a genetic testing. At least 29 identified causative mutations in ryanodine receptor. And presence of any is diagnostic for malignant hyperthermia. Absence of mutation must complete muscle biopsy and done this test, caffeine halosan contracture test, invasive one. are non-trigger anesthetic agents that does not produce MH or malignant hyperthermia. You see thiopental, sodium, pancuronium, droperidol, benzodiazepines as stereotype local anesthetics, nitrous oxide, and ketamine. Should we do prophylaxis with intravenous dantrolene? No, it's not necessary if these safe agents are used in patients with history of malignant hyperthermia. And if you hear that one patient died suddenly during the anesthesia without any probable cause, it's mostly from malignant hyperthermia that is not detected immediately and measures that does not prevent later complications. So early signs and later signs. Early signs should be recognized like metabolic tachypnea, elevated production of carbon dioxide, and increased oxygen consumption, and of course combination metabolic and respiratory acidosis from hypermetabolism and production of carbon dioxide. Profuse sweating and mottling of skin, tachycardia, arrhythmias, masseter spasm if succinyl has been given, and generalized muscle rigidity. In times that you are giving anesthesia to the patient and patient is relaxed by administration of muscle relaxants. And later signs like rapid increase in core temperature, like 1 or 2 degrees. It means like patient have 36.6 normal body temperature and increased by 2 grades, so have 38.6, and it's fever already. More than 38 grades is considered fever. Rhabdomyolysis is the destruction of muscles. Grossly elevated blood creatinine phosphokinase and myoglobin levels from destruction of muscles, and darkly colored urine. Hyperkalemia, of course, from muscles which is released, severe cardiac arrhythmias, and disseminated intravascular coagulation or DIC. Differential diagnosis should be done with following diagnosis or syndromes: insufficient anesthesia and or analgesia if you are giving subnormal or under normal doses or related to patient weight if it is not calculated well. Infection or septicemia, insufficient ventilation, anesthetic machine malfunction if anesthetic machine does not give the required volume, tidal volume, to cover demand of the body. Anaphylactic reaction, pheochromocytoma, thyroid crisis or storm, cerebral ischemia, neuromuscular disorders, elevated yen tidal carbon dioxide level due to laparoscopic surgery, which use carbon dioxide because of using oxygen instead insufflation of oxygen in the created cavity of the abdomen can trigger fire, and for this reason they are using carbon dioxide. Use of drugs of abuse if a patient is abuser of any of the drugs, and malignant neuroleptic syndrome we'll discuss later. This one is from administration of antipsychotics. Treatment of acute malignant hyperthermia. It should be treated as soon as possible as detected or suspected malignant hyperthermia. Immediately stop administration of trigger agents like inhalatory anesthetics. If you are using, for example, sevoflurane or isoflurane, and inform surgeon to terminate or postpone surgery or to stop at least. Hyperventilate patient with 100% oxygen using 2 to 3 times the normal minute volume, so increasing tidal volume and increasing oxygen fraction to 100. and administer dantrolene, which is the only one and proven that help and work in MH. So dose of 2.5 milligram per kilogram rapid intravenous push through large bore intravenous catheter or central venous catheter if it is placed already, and no less than 1 milligram per kilogram should be given. Higher doses are often necessary, and the initial dose should be repeated until you see signs of reversal, or at least no manifestations of some signs, early or late, of malignant hyperthermia. The maximum dose should be 10 milligram per kilogram, and large doses up to 30 milligram per kilogram may be needed. Here you see a preparation, which one is required dilution with at least 60 milliliters of sterile preservative-free water, which is incompatible with normal saline or dextrose 5 and other acidic solutions. Storage should be done at room temperature, and after preparation 6 hours, and it expires. As you see, do not prepare infusion in glass precipitates. Use sterile plastic bags only. Treatment of acute malignant hyperthermia with other methods or physical appliance, like administer bicarbonate for metabolic acidosis, 1 to 2 milliequivalent per kilogram if no blood gas values are available. If you have blood gas analysis, you can compensate with respiratory factor or renal by administering bicarbonate. If temperature is high, like more than 39 grades of Celsius, cool the patient by applying ice to surface, lavage of opened cavities if they are opened, infuse cold non-normal saline infusion intravenously, cease cooling once temperature is below 38. Treat dysrhythmias by addressing acidosis and hyperkalemia, which are the causes, and use standard drug therapy, except do not use calcium channel blockers in conjunction with dantrolene, which are normodipine or nimodipine. Of course, you have to monitor everything that you are doing, like end-tidal carbon dioxide, electrolytes, blood gases, core temperature, creatinine kinase, urine output and color, if this one is of pale or which color is yellow or brown. Coagulation studies to rule out coagulated intravascular dissemination. A rise in creatinine phosphokinase and or increased kalium, or a fall in urine output, oliguria or anuria to less than 0.5 milliliter per kilogram per hour, that requires induction of diuresis at a rate of more than 1 milliliter per kilogram per hour, which is normal diuresis, and you are measuring this. Of course, patients have catheterization of bladder, and this reservoir will show you every hour accumulation of urine. Bicarbonate should also be given to alkalize the urine and prevent myoglobin and induced renal failure. So you have to infuse patient a little bit more solutions like normal saline or whatever you want, and increase diuresis to eliminate this creatinine phosphokinase and myoglobin, that can accumulate in the renal system and block kidney with anuria. Due to risk of recurrence, observe patient in intensive care unit after awakening patient from anesthesia for at least 24 hours. Give dantrolene with the following doses and infuse by continuous infusion 0.25 milligram per kilogram per hour, 24 hours. And continue to hydrate, alkalinize, and give diuretics to prevent this precipitation in renal tubules of myoglobin. Thank you very much for your attention. Hope this video is useful and can change your vision